PET-CT is a powerful tool for assessing patients who have been treated for malignancies of the head and neck, but interpretation can be complicated by the effects of treatment and by artifacts that undermine our sensitivity and specificity. We'll start with a discussion of some basic artifacts that occur in PET-CT. Then we'll move on to talk about inflammatory causes of increased FDG avidity that might mimic tumor recurrence. We'll talk about the importance of image quality and doing good PET-CTs in order to avoid imaging pitfalls. We'll talk about the proper timing of PET-CT in the surveillance setting. And we'll talk about some unusual patterns of FDG uptake that might be confusing. And then we'll talk about other tumors that might come in to complicate the situation. Let's start with artifacts. There are some very familiar artifacts that you all know on PET-CT. For example, brown fat uptake. This is a stark example of how extensive brown fat uptake can be, and you wouldn't really make an error in this situation. But here's a situation where it might be a little more difficult. Yeah, there are some clues, some additional areas of fat uptake, but there is one particular area that is super bright, and you might be inclined to think that that is an area of recurrent tumor. The key, of course, is to look on the CT and find that there is no enhancing mass in that area, so you know that it's associated with the fat itself. How about muscles? Essentially any muscle in the head and neck can twitch during the uptake phase and cause increased FDG avidity above its counterpart on the other side or other muscles in the neck. But there are a few muscles that are particularly prone to doing this that should be very familiar to everybody. For example, the pterygoid muscles often have asymmetric uptake. Here's one of my favorites. This is the inferior capitis obliquus muscle. I don't know why this muscle, of all the muscles in the head and neck, so frequently has asymmetric uptake on PET, but it does. Here's a very familiar one. Everyone, I think, is used to seeing these two dots in the middle of the neck. That, of course, corresponds to the vocalis muscles, the true vocal cords. And they frequently have uptake because you can't ask a patient not to talk for an hour during the uptake phase. One of the most confusing areas of muscular uptake is the tongue. Whenever you operate on the tongue or whenever you treat a tongue that has been affected by tumor, invariably that tongue starts to fasciculate in the post-treatment setting. So you frequently get large areas or small areas of FDG avidity within the tongue itself. These can be very confusing. It's often right near where the tumor was initially. You've got to correlate with your CT images and make sure there's no enhancing mass in the tongue. You need to compare to previous examinations and make sure that the configuration of the soft tissue within the oral cavity has not changed to reassure yourself that you're dealing not with recurrent tumor, but just with muscular uptake in the tongue. It can be very asymmetric. It can look a lot like tumor on the PET alone. Here's another post-treatment scenario in which muscular uptake can be very confusing. If you just look at the PET images here, there is a rounded area of increased FDG avidity in the lateral neck after neck dissection, very concerning for recurrent disease. Maybe there's a clue here in the maximum intensity projection, very linear, longitudinal. That sounds a little more like a muscle. But look closely at the shape of the outer neck. See how there's a nice normal contour here on the left, but on the right, the neck is sunken in. We've lost muscle mass in the neck. That's the trapezius muscle that we've lost. And now you've got a clue about what's really going on. This is a situation where we sacrificed the spinal accessory nerve and the trapezius muscle has atrophied. Look at that asymmetry between these muscles. What takes over that role? The levator scapulae muscle. That's what hypertrophies to compensate for the loss of the trapezius muscle. The levator scapulae muscle can look just like a mass. You can imagine what the clinical contour of the neck here is. This can look just like a mass clinically and of course radiologically, and you saw how much FDG avidity was in that hyperfunctioning levator scapulae muscle. A confusing overall appearance. The association with of the muscle fibers with the FDG uptake is your clue, and a solid knowledge of this physiology, what happens when you sacrifice the spinal accessory nerve. This is another familiar one, compensatory uptake, really, really bright uptake on one side of the larynx. This is what happens when you have vocal cord paralysis on one side, the other side takes over, and you get increased FDG avidity on the side that's still working. This is probably my favorite example of physiologic muscle uptake. This is a patient who had tardive dyskinesia from psychotropic medications, and all of the muscles of mastication show increased FDG avidity. We call this the Wolverine sign. One of the clues that you're dealing with artifactual muscular uptake is the longitudinal configuration of the FDG avidity. But it's not a perfect clue. Sometimes you get fooled. This patient, even though it looks like longitudinal uptake, is really just a string of recurrent lymph nodes in the lateral neck. Here's a patient where there's clear asymmetric uptake in the lateral neck. This could be very confusing, except it's on the wrong side. Has this patient developed new lymphatic spread, contralateral metastases? No, this patient has atrophy of the parotid gland, and that's a normal parotid gland on the other side. Right? Patients who have surgery, patients who have been irradiated will frequently have diminished uptake within the irradiated salivary glands, and that asymmetry might be confusing. So this is glandular uptake. Here's another type of glandular uptake. What do you do when the entire thyroid gland lights up? Well, if the entire gland is lighting up, usually that is a thyroiditis and not a neoplasm. This can occur in response to therapeutic radiation, or it can occur from a variety of other sources of, say, subacute thyroiditis. It's when you see a focal area of uptake within the thyroid gland that you should become concerned. Some 25% of lesions with focal FDG uptake in the thyroid gland end up being thyroid malignancies. So when we see focal uptake within the thyroid gland, that's when we suggest a biopsy. Obviously, lymphoid tissue has quite variable FDG avidity both before and after treatment. We've been talking so far about PET artifacts that might be confusing in the post-treatment setting. How about CT artifacts? Well, streak artifacts off of dental amalgam are a constant problem for us. That doesn't change when we move to PET CT. You really can't see what's going on here. Thankfully, PET to the rescue, showing us this recurrence deep in the tonsillar pillar. Fusion artifacts are a real problem. We really, at my institution, don't use the fusion images directly off of the scanner because you frequently just get overwhelming uptake like this. I will tell you there is no cancer depicted on this examination. This is just an error in the dynamic range of the PET. We use third-party software to avoid this problem. Okay, let's talk about inflammation. After tumor, it is the other major way that you get abnormal uptake in the post-treatment setting. Infection can be very confusing in a patient who has undergone surgery. You can see there's a large mass here deep to the patient's reconstruction flap, right around the surgical clip, a perfect location for recurrent tumor, and this bulky mass, I called it tumor. Here is the CT after a couple of weeks. I thought maybe this is a response to therapy with a fistula formation. Here is the PET, and there's extensive FDG uptake. I felt like that really confirmed that this was all tumor. But they asked us to put a needle in it. We aspirated this, and pus came out. This is all a postoperative abscess. This is a familiar infection to people who read PET-CT in head and neck cancer patients. Patients who have been treated for head and neck cancer often aspirate after their therapy, and so seeing aspiration pneumonia at the lung bases is a frequent potential artifact. Okay, this is an important point. Radiation causes inflammation in lymph nodes. I'm going to say that twice. Radiation causes inflammation in lymph nodes. At first glance, you might look at this PET-CT and say, oh, there's some uptake in this left 1B node. That's pretty worrisome. I'm going to call that a NIRADS 3. We're 2 months out from the conclusion of the radiation. But when you go back to the pre-treatment scan, the staging scan in this patient, there's plenty of lymph nodes, and 1B isn't one of them. This is just inflammation induced in an uninvolved lymph node from the radiation itself. That's a benign node. That should be NIRADS 2 at worst. Another example, exact same concept. This is a rounded node. It's got a little bit of FDG avidity. You're going to be worried about that, but if this was an uninvolved node pre-treatment, then it probably does not harbor cancer. It is probably just a response to radiation, NIRADS 2. Teflon injections. This slide has almost become anachronistic. We no longer use Teflon to augment the vocal cords because we realized it is not bioinert. It does cause an inflammatory reaction. So when you see uptake in a single vocal cord, and that corresponds to a well-defined hyperdense area within the cord itself, that is likely to be a Teflon injection to correct for vocal cord paralysis. If you think that this is enhancement and you see the FDG avidity, you can definitely see how this might be confused for uptake within a second primary or recurrent tumor. Healing bone has increased FDG avidity. Any healing tissue really has increased FDG avidity, but it's particularly confusing in healing bone in patients who have had reconstruction of their mandible and resection of an oral cavity tumor. Here's a patient who has extensive FDG avidity surrounding the reconstruction right where the native bone is meeting the bone graft. This is normal. This is expected. As this bone heals eventually, it will completely heal and there will no longer be abnormal uptake in that location. At first glance, this maximum intensity projection looks like there's 2 lung masses, looks like metastatic disease out there, very concerning. Here's the CT correlate. These are rib fractures, and you can see that there's extensive bridging callus around these healing fractures. I think the clue here is that the 2 are right on top of each other, oriented like rib fractures often are. We often see uptake along the course of the thoracic esophagus. This is esophagitis, and it is almost always the result of gastroesophageal reflux. In this case, the inflammation goes all the way up to the piriform sinuses. This is a really worrisome appearance on a maximum intensity projection. You can see lymph nodes all up and down through the neck and out into the axilla, maybe just some reactive nodes in the mediastinum, but a very concerning appearance overall. This is actually a patient with sarcoid, autoimmune disease mimicking metastatic disease. How about foreign body reactions? When a patient undergoes surgery for head and neck cancer, we do all sorts of manipulations. One of them might be insertion of a foreign body. For example, this is a patient who had maxillectomy for squamous cell carcinoma, and you can see right in the face here, right where we'd be worried about a recurrence, there's a bright lesion on the CT with extensive FDG avidity. That's pretty concerning. But if you look more carefully at the CT itself, that isn't enhancement, that's calcium. This is micronized hydroxyapatite. It is an injected material that was meant to add volume to the face as a cosmetic repair after this surgery, and it's inducing a foreign body reaction. Okay, let's turn our attention now to image quality. If you don't have good pictures, you can't make good diagnoses. And the theme here for this entire section is going to be using intravenous contrast. There are a lot of political reasons in the United States why we don't like to do contrast-enhanced PET-CT. I frequently see situations where a patient will get an attenuation-only PET-CT and then on the same day will get a contrast-enhanced CT of the neck and chest. That is absolutely a waste, and you're doing the patients a disservice in those circumstances. Find a way to cut through the politics and do what's right for the patients. Here's a post-treatment patient. There's a little bit of uptake left in one of the salivary glands. The other one's been suppressed by radiation, so no big deal. No real concerns here, right? Well, wait a second. What's that? There's no FDG avidity there. That's got to be okay, right? Let me just blow that up and we can get a better look at it. When you look at it on the CT, there's clear mural nodularity and enhancement in this. There's a necrotic center. This is a necrotic metastasis. It's got no increased FDG avidity, but it is still abnormal. This is a situation where iodinated contrast saves us. If we just had an attenuation-only PET-CT here, and this had no uptake, we'd blow right by it or think that it was a successfully treated node. It's only once you see the necrosis and see the mural nodularity that you can make the correct diagnosis of recurrence. Here's a patient with a lot of FDG avidity out laterally. Turns out that's all muscular. Symmetric uptake in the tonsils. No big deal. But once we have iodinated contrast on board, you can actually make out the discrete mass in the tonsil, despite all the streak artifact. Discrete mass there that is the tumor. This is a patient who had an attenuation-only PET-CT for surveillance, and there's an area of FDG avidity there, but really nothing seen on the unenhanced CT component. Probably just a little bit of granulation tissue in there. No big deal. Unfortunately, this is that same patient 3 months later. You can see that that actually was recurrent disease there, and it has exploded. Unfortunately, we blew it off because we didn't have the intravenous contrast there to inform us of that diagnosis. I know I'm hammering this home a little hard, but I really believe in this. Here's another example where we had a little bit of FDG avidity underneath this flap, but wasn't overly concerning until we had a really close look at the contrast-enhanced examination, and you can see that's actually a retropharyngeal lymph node with some central necrosis to it. No way you'd be able to pick that out without the use of intravenous contrast. Another way to get bad images is to ignore blood glucose level. I know we all do this routinely, ensure that patients don't have a high blood glucose level, but if they get through, this is what happens. All of their soft tissues take up the fluorodeoxyglucose, and you can't make out individual lesions. Let's talk about timing. When should we be doing PET-CTs? When should we perform the first PET-CT after the conclusion of therapy? Most people shoot for about 3 months. The literature says that there's really no difference between 2 months after therapy or 3 months after therapy, so you can get a little bit of a jump on that and do it at 2 months if you like. If you go earlier than 2 months, you start to get into a range where you get a lot of false positives and a lot of false negatives. You get false positives because there's still surgical healing, and just like those examples of bone healing, the soft tissue healing after surgery will have physiologic FDG uptake that can look like tumor recurrence. Radiation effects work the same way. For several months after therapeutic radiation, there's still healing tissue there that can mimic recurrent disease. There are also false negatives that occur in this time frame. The tumor has not had a chance to start regrowing yet, so it may be too small to appreciate on PET. If we start going out to 4 months, 6 months, waiting too long, we may have lost an opportunity to cure the patient's recurrence that we would have picked up at 2 or 3 months. Even too soon after chemotherapy, we can see rebound of the bone marrow that may look like bone metastases. This is actually a PET-CT. It looks more like a bone scan. But there are no Mets here. This is just rebound after chemotherapy. We all base our interpretation on expected patterns of uptake. There are expected areas where we know tumor is likely to recur, but are there situations where unexpected patterns arise and might confuse us? Squamous cell carcinoma of the head and neck associated with HPV can sometimes result in bizarre metastatic patterns. We don't think about squamous cell carcinoma of the head and neck going down to the pelvis. In fact, it occurs almost never unless there are intervening thoracic metastases, but HPV is an exception, and you can get bizarre distant metastases with HPV-associated squamous cell carcinoma, like this isolated metastasis to pelvic lymph nodes. Be careful in the setting of bulky disease with a near complete response. We are so used to seeing head and neck cancer completely disappear when it has been successfully treated. But if you start with bulky lymphadenopathy, you may get an excellent response with just a little bit of CT and PET abnormality where a large node used to be. That's actually a good sign, and the literature suggests that these patients have a very high likelihood of being completely cured to the point where these should be called NIRADS-2 lesions when you have bulky disease that has a near complete response. A complete response would get you to NIRAD-1, but a near complete response should be a NIRADS-2. It's not that suspicious. Do be careful though, because mucosal disease, while it may not go entirely back to normal on PET, should become just a thin residual rhythm of enhancement on CT. If you can still see bulky enhancing tissue at the site of a large lesion, that's still worrisome, and this should be in your NIRADS-3 classification, or 2A if you want to get them just to look at it, 3 if you want to ensure that they biopsy it when they look at the mucosal surface. Bone metastases can be very difficult to find on CT. Thankfully, it's PET to the rescue. I suppose there's a little bit of sclerosis there in retrospect, but I was going to absolutely overlook that sternal metastasis. Another example of hidden bone mets that there's no way I'm ever going to pick up on this CT. There they are, even in retrospect. I had no hope here. PET to the rescue for hidden bone mets. Are there some pitfalls that occur just because PET-CT is not the right exam? Yeah, perineural spread is a great example of that. Every once in a while, you'll be able to pick up perineural spread on PET, but it's certainly not reliable for this diagnosis the way that MRI is. And in tumors that are likely to have perineural spread, or patients that have already documented that propensity in their tumor, you really got to be using MRI. Now, you could be really fancy about it and use PET MRI and kill 2 birds with 1 stone, but don't rely on PET alone to find that perineural spread. Tiny little metastases, obviously the most difficult thing that we encounter in imaging. You know, these Mets have to start somewhere. They're going to be small before they're detectable. And PET can sometimes be helpful. Sometimes if they're necrotic, you need the CT. This is a great example where the fused PET CT is far more powerful than either of the two component modalities alone. Small metastases. Another pattern that can be confusing is a delayed recurrence. We know that in the age of PET, 75% of recurrences can be detected within the first year after the conclusion of therapy, 95% within 2 years. So once a patient gets out beyond 2 years, we start getting a little cocky, we start getting overconfident. The likelihood that there's actually going to be disease is extremely low. I'm showing you the CT component of a PET CT from a patient who's 38 months out, over 3 years out from the conclusion of her therapy. And sure enough, there's the recurrence. It's not that guy back there. There's the recurrence. Very difficult to pick up. Another weird or unusual pattern that we need to be aware of is the complete physiologic response. Sometimes you have a bulky lymph node that would have, before the age of PET, forced a patient to undergo a planned neck dissection. If we can document a complete physiologic response, that patient doesn't need surgery anymore. But it has to be a complete resolution of the FDG avidity within the lymph node. Even if it's still pretty big, if there is no more FDG, that patient can be watched as a NIRADS 2 instead of undergoing a planned neck dissection. There are other tumors that we might encounter besides the one that we are looking for as we search for recurrences. Benign glandular neoplasms are famous for having abnormal FDG avidity. Warthin's tumor in particular, oncocytomas as well. These can be very confusing in a head and neck cancer patient where this might be a reasonable spread of lymphatic disease. But this is just a Warthin's tumor, benign. Glandular malignancies are just as dangerous in the opposite direction because glandular malignancies may not be PET avid. Now you can look at this axial image all you like. I don't think you're ever going to pick up this metastatic disease from medullary thyroid carcinoma. It's just not FDG avid. There's another example where IV contrast really helps us out because these glandular malignancies tend to be very vascular. Another example, same basic idea. This is a patient with extensive metastatic disease, and this maximum intensity projection really misleading. Numerous lung metastases from adenoid cystic carcinoma. This is an example to sort of emphasize how confusing it can be to distinguish glandular malignancies from benign lesions. There are bilateral masses in the thyroid gland here, and your job is to figure out which one of these is the malignancy and which one of these is benign. Good luck. That's a colloid cyst. That's follicular thyroid carcinoma. I've got no hints or clues. Second primaries are so common in patients with head and neck and lung cancers. We've always got to be on the lookout for a metachronous primary tumor when we're looking at surveillance scans. For example, this is a patient who had a squamous cell carcinoma of the oropharynx and on post-treatment scanning presented with this adenocarcinoma of the thoracic esophagus. And that concludes the lecture on interpretive pitfalls in PET-CT of head and neck cancer.